Eastern Memorial Hospital. She's also, because of her academic interests, include clinical and basic research on dry eye disease, corneal and refractive surgery, cataract and functional lens surgery, and corneal and external eye diseases, make her a wonderful ophthalmologist. She has published more than 100 SCI articles, and she also won several national and country awards for her enthusiastic devotion. Now over to you, ma'am.
I'm going to address these highlighted goals, which can you show us next? The next. These highlight goals include identify patient correctly, improve staff communication, use medicine safely, prevent infection, identify patient safety risk, and prevent mistakes in surgery. So can you show the next? So to make sure that each patient gets the correct examination, medicine, and treatment, we improve the accuracy of patient identification by using at least 2 ways to identify patients before examination, procedure, and surgery. These include asking open questions such as the patient's name and date of birth, as well as checking the health ID card with a photo at the OPD and OR, and restring in the OR. Next. So to improve staff communication, we use smart hospital approach. Next. At the outpatient service, the patients swipe their health ID cards outside the clinic to notify the nurse inside the room without disrupting the doctor and patients inside the clinic. Patients reporting their arrival are the previous one, please. Sorry, we should be in, yeah, this one. So patients reporting their arrival are displayed in different colors on the nurse screen for their ease of assisting workflow. Since there is a great proportion of all patients having hearing impairment and a certain chance of patients with similar names that could be mistakenly called, this system not only improves the outpatient service workflow, but also reduces the chance of mismatching patients in the busy outpatient service. Next. So to improve staff communication in the OR, the surgery list displays the patient status, including arrival, entry into the OR, preparation in progress, and end of surgery. The information is also displayed in different colors on the screen throughout the operation areas. Next. The double screen in the operation room facilitate confirming patient surgery information, including patient's name, next, and the site of the operation. Next. Next. So to get important test results to the right person on time, the examination results are linked to patient's EMR at the time of examination to minimize potential mismatching. As all the results are on the same list, doctors and nurses can easily assess the necessary examination results with minimum efforts. For example, on the left is the patient's EMR. By clicking the indicated icon, the list of examination is shown in the middle. A glaucoma patient would need fundus photo, OCT, visual field evaluation, as well as optical biometry and variant examination before cataract surgery. They are all on the same list. Surgeons verify the IOL type and power of the patient by clicking hyperlink icon shown in the middle panel and finalize the optical biometry report as shown in the right panel. If any data are missing, the missing parts could be easily identified and corrected, as all the examination results are linked to the patient's EMR. Implanting an IOL with wrong power is less likely. Next. To improve the safety of using medications, it is important to label medicines that are not labeled before procedure. Using stickers to label intraoperative medications is difficult in ophthalmology, as the medications are delivered in syringes, and applying stickers would obscure the scale on the syringe and at the risk of detaching. Thus, we use different sized syringes to differentiate the medications. For example, for standard cataract surgery, topical anesthetics for the ocular surface are in a 3 ml syringe, while intracameral anesthetics are in a 1 ml syringe. When the intracameral epinephrine is needed for intraoperative pupil dilation, it is in a 1 ml syringe with a yellow rubber band. The balanced salt solution is in a 5 ml syringe. Using this approach, medication confusion is less likely. Next, endophthalmitis prophylaxis for elective cataract surgery is an important issue. The use of perioperative peridine iodine and an eyelid speculum, drape with isolation of eyelids and eyelashes, as well as meticulous sterile preparation, is effective in limiting the incidence of endophthalmitis. There are more cataract surgeons considering adopting intracameral antibiotics recently. However, in this era of increased awareness of compounding error, it is important to recognize that vancomycin, cefuroxime, and moxifloxacin are not available in a prepackaged form for an intracameral use in most countries. Vancomycin and cefuroxime must be reconstituted from powder form in the operation room, creating a significant risk of dilution errors and contamination. We thus use moxifloxacin as it demonstrates dose-dependent rather than time-dependent kinetics. It also has a lower risk of allergy and is more easily prepared from the preservative-free bottle without dilution errors. Next, to prevent nosocomial infection, we use the hand cleaning guidelines from the CDC and set goals for improving hand cleaning. To reduce aerosol-related infection due to the short distance between patients and staffs in ophthalmology, we also explain and instruct the use of mask and a tape on top of the mask. Next. So we provide sufficient alcohol for hand cleaning in the hallways for patients, family, and personnel. Next. At the outpatient registration corner, patients take a ticket from the touch screen of the ticket machine for the order of examination. They are instructed to clean their hands with alcohol at the side of the ticket machine before touching the screen. Next. At the reception desk, all personnel are encouraged to use alcohol for hand cleaning. Next. And at the visual acuity checkup room, the examining technician and optician use alcohol for hand cleaning before visual acuity checkup for each patient. Next. They also use alcohol for hand cleaning before applying eye drops to the patients. Tissues are given the patient immediately to wipe away eye drops residuals. Next. Bottled alcohol is at the side of the EMR screen for physicians' hand cleaning in the clinic before and after typing records. Next, we encourage personnel and patients to wash hands whenever needed, providing soap at the side of the clinic sink and alcohol at the clinic entry. Next, there is bottled alcohol for hand cleaning before touching relevant materials in the treatment rooms. Next, and at the side of the patient educational materials for technicians, hand cleaning in the education room before and after touching the education materials. Next, the bottled alcohol is also provided at the side of the electronic signature iPad for patient's family hand cleaning in the post-operative explanation room before signing the electronic explanation sheet. Next, to reduce infection risk in the era of COVID-19, all patients are provided a tape on top of the mask to reduce ventilation-related aerosol and infection risk. Next, we provide sufficient masks for patients and personnel, a tape on the top of the mask to reduce ventilation-related aerosol and infection risk. A mirror is provided for those that apply the tape on themselves. Most patients need help from the staff for tape application. Tissue is free to use for cleaning all the time. Next, we used Q-tips for eyelid manipulation to reduce contact and infection risk. The box to hold the Q-tips is fixed to the side of the slit lamp for ease of use. Finger touch is rarely needed during the entire outpatient visit. Next, the slit lamp shield also reduces close work distance related infection risk. Next. There are 4 commonly encountered patient safety risks in an ophthalmology surgery. For patients currently taking anticoagulants, the system pop up a warning automatically, suggesting the surgeons to explain potential bleeding to the family and take necessary preventive measures. In addition, the other most commonly encountered patient safety risks are hearing impairment, dementia, and claustrophobia, which may lead to suboptimal cooperation and surgery complications as we operate on most patients using topical anesthesia. These patients need additional attention in verbal communication for a smooth surgery. Next. So a microphone is placed under the eyepiece of operation microscope and adjusted for the surgeon's position. The speaker on the side of the better hearing ear facilitates communication during operation, particularly for patients with significant hearing impairment. It also improves cooperation of mild dementia and claustrophobia patients. Next. Patients wear a mask for surgery during COVID-19 pandemic. Difficulty in breathing decreases the patient's cooperation and thus is a special concern. The O2 cannula underneath the mask facilitates breathing. The tape on top of the mask prevents air leaks to reduce the potential infection risk of the personnel. An instruction on operation procedures and simultaneous simulation immediately before surgery enhances operation smoothness. Next, to prevent mistakes in surgery. Next, at the clinic, we use slit lamp photo and video to document anterior segment pathology. Next, and retina ultra-wide field image to document posterior segment pathology. Next. Examination data are uploaded into PACS system immediately after examination and linked to patient's EMR to reduce errors. Next. A microphone is placed under the eyepiece of the slit lamp to facilitate preoperative communication to confirm eye of surgery. This is very useful. Next, as many patients have some degree of hearing impairment. Next, in the OR, to make sure that the cataract surgery is done on the correct patient and on the correct eye, we mark the eye with a sticker when the patient arrives at the check-in counter. Next, to prevent the sticker from detaching, we secure the sticker with a second layer of tape. Next, once the patient is brought into the OR, the surgeon confirms all the relevant information by clicking the EMR to the patient information as mentioned earlier. Next. So in summary, these are what we have done to improve patient safety. The key components are identify patient correctly, improve staff communication with a smart hospital approach, label all intraoperative medications using different size syringes, prevent infection by hand cleaning, mask, and the tape on top of the mask to reduce potential infection, use an intraoperative microphone for better communication, and label the surgery site with a sticker and a second layer of tapes. Next. So at the end of our talk, I would like to thank the committee and secretariat for the invitation again, and thank everyone for your attention. And I am sorry for the technical error, and enjoy the rest of the meeting.